Good evening, everyone. I'm going to get started now. My name is Emelia Bachman. I work at the Delaware Institute for Reproductive Medicine. We are part of the Boston IVF Network. I'm so happy that you're joining us today for our Q&A. I'm so happy to answer your questions and get to know all of you. So definitely we have some questions that were already sent. And definitely you can send them, feel free to send them on either in the chat box or the Q&A, whatever is easier for you. And I'll do my best to answer everyone's questions. A little bit about me. I grew up outside of Philadelphia, and I am now in practice over about almost 10 years now from fellowship. I trained at both the University of Maryland and the University of Pennsylvania. I did my fellowship at the University of Pennsylvania and have been in reproductive endocrinology, like out, seeing patients on my own for over 10 years now. My partners, Dr. Jeffrey Russell, who is the founder of the practice, he was there for over 30 years and still with us. And Dr. Kovalevsky as well has been in practice over 20 years. So the three of us are really happy to take care of you. And we really want to get to know you, and you can make an appointment whenever you want. I'm going to start answering some questions. So I have here, the question is, I'm 40 years old and it's going to be my first pregnancy, and I did a transfer 2 weeks ago. And the grade was 8 cells. Is there a chance? So this is a really great question. The success of any treatment cycle really depends on our age. Now, as we get older, the eggs become more and more unhealthy, unfortunately, and there can be other factors involved. With grading, we think that embryos that are graded better are associated with better pregnancy rates, but we have seen patients who get pregnant with lower graded embryos. So it really not what the embryo looks like does not necessarily mean that this will not be a healthy child. So I've had patients with picture perfect embryos, unfortunately not get pregnant or have miscarriages, and I've had patients who've had not so great looking embryos get pregnant. Now, sometimes we're transferring the embryo without doing any genetic testing, and sometimes you're choosing to do genetic testing. So those are two different situations. So often, if we don't know the genetics of the embryo, the older we are, the less chance that the embryo has of implantation. And so when we test that embryo, we're able to see if it is genetically normal. And again, the testing is not perfect either. It's about 98 to 99% accurate. So there isn't a perfect test. And also we do have data that maybe that's not for everyone. So certainly when we're making this decision for you, we're individualizing your care and deciding, based on your age, your diagnosis and the grading of your embryo or your wishes for the embryo. Are we going to do genetic testing or not? You can see that we see that embryos that are genetically normal but may have a lower grade still have an excellent chance of becoming a live birth. I know it's really frustrating to have a negative pregnancy test, and my heart goes out to you, and I'm so sorry about what happened. I do suggest trying again. We see that especially with age, some patients need multiple cycles. Each month we have a different group of eggs. And also what we can do as your doctor is look back at the cycle and say, okay, how was the stimulation? How many follicles grew? How many mature eggs did we get? What were the estrogen levels? How was the fertilization? How was the embryo development? So at each step, we can take a look and see what is happening, and then how can we improve on that in the next cycle? So I definitely suggest trying again. And I think that it is difficult, but we're here to support you. And you may also want to, think about, do I want to get genetic testing or not? Again, it's not perfect and it's not necessarily for everyone. So you have to talk to your doctor. I think you also asked why acupuncture was suggested. So there are data out there, some small studies that perhaps acupuncture can help blood flow to the uterus, blood flow to the ovaries. It certainly is an alternative treatment to help patients with fertility, with their egg reserve. That having been said, we do not have the definitive study that proves that this definitely improves live birth. And so we have some smaller studies that suggest some good results. And then when they kind of compiled all the studies together, they did a meta-analysis. It did not show much difference. But again, this is something where I individualize the care. For many of my patients, they want to do everything possible. And we know that as an individual, that may affect you differently than someone else. So my feeling is if it's helping you, if it's lowering your stress levels, if you feel like this is something you want to do and is helpful, then I would definitely recommend doing it. If it's something that's really, you don't like needles, or it's really expensive for you, or it's something that's stressing you out more, I would not do it. So it is an adjunct that we use for some patients, but we don't recommend it 100% across the board. It's a good question. What are your thoughts about FET protocols post-endometriosis excision surgery? Are there implications for protocol selection? Okay, good question. So there are some studies that show perhaps with endometriosis, we should do a couple of months of suppression after surgery to help suppress the endometriosis and improve implantation rates. I have seen both sides of this. I have seen some patients who I think they definitely needed this, and some patients where we did surgery and we were able to move right into an FET cycle. Often with endometriosis, I'm using a programmed embryo transfer. We're using, estrogen pills or patches, or vaginal estrogen and progesterone injections. Again, I think you need to talk to your doctor about what might be right for you, because again, what might be right for one person may not be right for the other. And so typically I do use program cycles after endometriosis, and for some patients, I may elect for some months of suppression beforehand. Okay. Sorry, just looking at this. So someone also asked, do you need to have complete bed rest after embryo transfer? The answer is no. Certainly, I think you need to do what you feel is best for you. We have seen that just strict bed rest after the embryo transfer is not necessarily helpful. Typically, when we do the embryo transfer, we do let you get up to use the restroom. We don't think laying there with a full bladder that's probably causing some more cramping is really helpful. Remember, it's a completely different organ, so the embryo will not fall out, we promise you. So we do like you, we have you there for a minute, go over your instructions and make sure you have everything that you need and all your questions answered, and then you can use the restroom and leave. We don't want you to do anything too strenuous, right? I always tell my patients, it's not time to climb Mount Everest. Some of you may have already heard this from me. It's not time to run a marathon, but you can be a normal person. And I don't want you to lay there thinking that every cough or sneeze is going to affect, your pregnancy. At that point, you've done everything possible. We've made sure that your lining is good, your hormones look good, the embryo is put back. We do it under ultrasound guidance. We do everything we can to optimize those chances. And from there, you've done everything right. And I think that's one of the harder things, because we know that you would do everything possible, but you don't have to, lay there and stress yourself out either. But do what you want to do. If you want to relax for the day, definitely do that. I always tell my patients, go have a fun lunch afterwards and then do something that you really enjoy. And just nothing too stressful. This is the question for, I'm so sorry. This is a patient who you just had the loss. My heart goes out to you. I'm really sorry about that. And I'm heartbroken for you as well. You have 2 tested girls left. Should I transfer one or both? I know you're scared. So what I would do, I still would recommend one healthy embryo at a time for a couple of reasons. One is that you're giving each embryo its best chance in a separate cycle. So the first thing I would do, if this, for my patient, is to take a step back and say, okay, is there anything we can retest? Can we retest the uterus? Can we do any other testing to see, was there a reason for this? I think it's especially heartbreaking to have any miscarriage, but when you feel like this is genetically normal and then this happens, it's especially hard. And so remember that there may be other things going on. And so as your doctors, what we can do is take a look at everything and make sure before, we just reimplant another one. We've done enough more testing, maybe rechecked a few things, recheck your uterus, and do everything we can for you. So the next step is with how many embryos to transfer. I'm going back to one at a time because, again, you want to give each embryo its separate chance. On one hand, you could end up putting 2 in, and maybe there was something with the lining that we couldn't really see, like either on the ultrasound or with the blood levels, and you want to give each embryo a separate chance in a separate month. The other thing is, if you do get pregnant with both, unfortunately, there is a higher rate of miscarriage with twins. There's a higher rate of miscarriage, preterm birth, preeclampsia, developmental problems. And again, we all know lots of people who have twins and triplets or more that their children are healthy, and we're really happy about that. But we don't want to cause that problem if you've already had that. Again, I'm sending you a big hug. I'm so sorry about that. And we just hoping that you get through everything well, and just want you to be okay. You guys have really great questions. I'm sorry, I'm trying to, good question. I had a transfer of a high quality embryo that was tested normally. Why did it not implant? This is also really frustrating. I understand. Remember that we typically are seeing anywhere, around 60% implantation for seemingly genetically normal embryos. Remember, this genetic testing is accurate with roughly 98% accuracy. We can test for the chromosomes. So there's other things we cannot test for. I'm assuming you did have everything checked before with your uterus and other lab work beforehand. And I think if the lining looked good and the estrogen looked good, it's very reasonable to try again. If you look at some studies that show where patients have implanted, 1, 2, or 3 normal embryos, after 3 normal embryos, you will see over 80 to 90% live birth. So sometimes we do just have to try another one. I have had patients who've had, unfortunately, miscarriages even with a normal embryo. It is upsetting, and many times we have to try another one. So I know it is really frustrating, but I always tell patients we have to consult afterwards, have a post-treatment consult, look at the protocol, make sure all your testing was updated, make sure I wouldn't recommend anything else for testing before we proceed with another one. And you always want to just take a step back. Sometimes it is the right thing to do the same protocol because you responded well and the lining looked good and the estrogen levels were good, but we always want to take a step back and evaluate it and make sure there isn't something different we want to do. Again, amazing questions. I love it. I wish you were all here with me. That would have been more fun. Okay, I'm in my 40s and we'll be doing another cycle with a physician who's willing to work with older patients and has been successful. That's wonderful. I think that's really good to find someone you feel really comfortable with. What are your thoughts about CoQ10? So CoQ10 is an antioxidant. There are some small studies that have suggested improved egg quality, improved IVF success. That having been said, again, we don't have definitive randomized double-blind control trials. But with CoQ10, it's an antioxidant. It's quite safe, and we, it's in all of our cells. And so there's some data that maybe that this can potentially help. I don't think this is going to hurt you. The dosing in the study that was probably the better of one was about 600 milligrams daily. And I tell my patients, if that's something you want to do, I don't think it will hurt you. Some people use it for, heart health. So there are definitely a lot of benefits. Also, some of my urology friends have male patients take it as well for sperm quality. We have a question about how long will I have to wait to start IVF after I start the injections? So let me, we'll take a step back. Okay. So basically you're taking injections for the IVF cycle. So I always like to compare the IVF cycle to our natural cycle. In our natural cycle, at the beginning of the month, a whole group of eggs is recruited. And out of that group of eggs, if someone is having regular cycles, one follicle will be chosen, and the rest die. What happens with IVF is we're giving you higher doses of FSH, the same hormone that comes from your brain, to try to rescue more of those follicles from their programmed cell death. So we choose these doses based on your age, your weight, your AMH, your follicle count. So we take a lot of things, a lot of factors into consideration when picking your dose. So basically you are taking the injection. So you'll be taking 9 to 14 days of injections daily. And some protocols have maybe 2 to 3 injections. Some may have more. Again, it depends on your egg reserve, your age, and what your doctor has chosen for you. And so most of the time, most people are ready for the egg retrieval somewhere between 9 to 14 days, but it can be, everyone is different. I have some patients who take a little longer and they do well, but most people fall in that. So then when the follicles are ready, meaning they're mature, we see a nice cohort of mature follicles where most of them are of a good size and we have a good estrogen level. Then we decide when to trigger the ovulation and we pick a certain time, and then you come into the office. It's either 35 or 36 hours. Some people do a little differently. So that's when we can do the egg retrieval. So basically you're doing about 2 weeks of injections to get to your egg retrieval. So I hope that answers your question. I think if you want to have a follow-up, please put it in. This isn't so two. Oh, sorry, they keep on jumping around. Okay, 2 hope to be moms here. She's 37, I'm 35. Both would like to have a genetic connection and carry. That's amazing, so wonderful. What's the best way to begin to determine whose embryos are best to use? Great question. So I have to say that, the younger the eggs are, the better they are, but both of you are actually still in a good prognosis. So what I would have you do is I would have your doctor check both of your egg reserves. Remember, egg reserve tells me how you're going to respond to IVF. Your age predicts live birth. Again, you're both in a good place. So, you could potentially, so if you both want to have a genetic connection and carry, you could both try some insemination cycles if you'd want to, as long as, tubes are open and egg reserve is good. Or you could both do IVF cycles where you maybe use the same sperm and then each one of you goes through and then has the embryo implanted. So I think the best way to begin is just to have a conversation. I always say, what is the dream of your family? How can I help you? And then we can kind of figure out the best way to go about the treatment. And, I always say, I want to do what's right for you medically, but I also want to do what's right for you personally and know, how many children do you want? Do you want to carry a pregnancy? And in same-sex couples too, it's, do both couples want to use their egg? Do both patients want to use their eggs or sperm? And so we really come up with the best plan for you. Okay. This is a good question. Do you ever see no eggs? Luckily, rarely. Unfortunately, I have, and we all have. So sometimes people have follicles growing, and sometimes there are no eggs. Typically, the first thing I do is I wonder, did they take their trigger shot correctly? We check the blood work the day after the trigger to make sure someone responded to it. So we know that you did. But there are some times when the egg reserve is so low that you may see follicles growing, but you may not have eggs. I always think it's the most devastating when you get none. Sometimes we do have patients where follicles are growing and we don't get as many eggs as we expected, which is also really disappointing. But I know that that's really hard. So I always tell patients, 1 month does not mean that this is over. Many times you need to try multiple cycles. But yeah, rarely, but I have seen that. Is there a BMI requirement to do IUI? No, not in our office. We do want you to be your healthiest self possible. And that's really important, I think, for your pregnancy rates, for your own health, for the health of the pregnancy. But we care about you, and we also understand that, it's not easy sometimes. And, everyone deserves a baby. That is the most important thing. So we just want to make sure that, your testing is good, that you're a good candidate for either IUI or IVF. And then of course we will work with you. Okay. What is the likelihood of multiple pregnancies with one embryo implanted? That's a really good question. So you can have one embryo implanted and then that it could split into identical twins, which has definitely happened to me over the years. I can't, we can't prevent that from happening, but it does. It's roughly 1 in 100. So that's a really good question too. Okay, I'm 34 years old with PCOS and considering my first pregnancy. I've been on pills for over 5 years, which is, again, we know when someone has PCOS and they're not trying to get pregnant, that's one of the best treatments so that we can lower the male hormone levels and regulate the cycles. What are the first steps to take? So what I would do is, yes, I would start a prenatal vitamin. Typically, it's ideal to start a prenatal vitamin about 3 months before you want to start trying. But as long as you're relatively eating healthy, you don't necessarily have to wait 3 months to try. I typically have my patients stop the pill. You can some patients with PCOS may start to have some regular cycles, some may not, right? So, and typically you may see, I've seen roughly 30% of PCOS patients sometimes conceive on their own if they have that random ovulation. That having been said, you don't want to wait too long and you don't want to waste time. So my advice with PCOS is to see a fertility specialist earlier, almost right away, because you don't want to waste that precious time, and it can get really frustrating, if you're just waiting for a period. So often what we can do is update your PCOS labs, do some blood work, do an ultrasound, and then we can talk about, methods for ovulation induction. I do have some patients who tell me, hey, I'd really like to see what my period does. And then we kind of make a time limit. We say, okay, why don't you track things for about 3 months or so, or just put a little time limit on it, because we wouldn't want you to go so long without getting the right help that you need. Okay. I also recommend for patients, and again, I always do what you feel comfortable with, but if you're going to end up taking a medication or we're doing some sort of monitoring or treatment, I do like to do your fertility testing, because it is really disappointing if you end up perhaps taking something like Clomid or Letrozole, and then later on finding out that your tubes were blocked, or you had a polyp, or the sperm was low, right? So a lot of times I like to get all that testing up front so that you already know that there is an issue with fertility, and then you don't want to have any other questions. Okay. Of course, I have some patients who look at me and they say, listen, I don't want that, I don't want that yet. And I'm a little afraid of this test, and that's okay too. We work with what you're comfortable with, and we kind of find a timeline that you feel good about. Okay. Okay. I am a female. We have a 35-year-old who has diagnosed with Synechiae, or these are adhesions in the uterus. And does this inhibit you from getting pregnant? So yes, it can. It can affect the development of the lining. It can affect the implantation. So typically what we do is we do what's called a hysteroscopic lysis of adhesions. You do it while you're sleeping, so you don't feel any pain. We put a little camera inside the uterus, hysteroscopy, the uterus, scope the camera. And so you're doing this while you're asleep. And then we can take a little scissor and we can very gently cut out the adhesions to normalize the uterine cavity. It depends on how severe they are. Some patients may need multiple surgeries if they're very severe. If they're really mild, it may need only one. Often, and everyone is a little bit different, but often someone may put an intrauterine balloon in there for, maybe 3 to 7 days to prevent adhesion reformation while the uterus is healing. And typically we use a course of estrogen and then progesterone. So it is actually, for many patients, it's easily treated. I have had some patients who've had very severe scarring. I think the most severe cases, people may be thinking about a gestational carrier, but it is very reasonable to try to treat them. And I very successfully treated many patients and they have conceived. So the first step is the hysteroscopic lysis of adhesions. And then we see how you do. But again, it can depend on how severe things are. This is another great question. They're all great, by the way. I've been trying for 1.5 years and had a very early miscarriage and haven't been pregnant again in over a year. We've been tested and told everything is fine. Is it too soon to start looking at IUI and IVF? I am so sorry. Again, I'm so sorry you're going through this. I think if you have been trying for over a year, and you're told everything is fine, this falls into the diagnosis of what we call unexplained, which can be very frustrating for patients, right? It means your tubes are open, the uterus is normal, the egg reserve is normal, and the sperm is normal. That having been said, it doesn't mean there isn't something that can be helped. There may be a cervical factor. There may be an issue with fertilization or implantation. There may be endometriosis that you're not. So sometimes people may do a laparoscopy to take a look at that. So there may be some issues that are going on. And so, yes, I don't think it's too early to start looking at IUI or IVF. IUI could potentially be helpful because we use a medication to potentially get an extra egg to grow. We can use a trigger injection. We then wash the sperm, get the best swimmers, and get them closer to where they need to be. So it's a lot of things that are different than trying on your own. Now, depending on your age, and it's going to be lower if you're older, like over 40, but typically IUIs are only about 10% a month. You see roughly 30% of couples will conceive after 3 IUIs. Now, after that, we do recommend IVF. Sometimes, there may be merit to just moving directly to IVF if you don't want to, spend the time doing the IUIs. Again, this is a personal decision. And I always talk to you about those options, and you should talk to your doctor about those options, but which way is best for you. With IVF, it offers the highest chance for success, and it's particularly in this situation because you can see the eggs and see the sperm and see the percent that fertilize and let those embryos develop. And we do see, we see that not every follicle has an egg. Not every egg is mature. They don't all fertilize. They don't all develop into embryo, and they may not all be genetically normal. And again, based on your age, you may or may not do genetic testing or your wishes. So that gives us the highest chance for success in the situation with the lowest risk of multiples if you're putting one healthy embryo in. And it also can give us more information because we can actually see the eggs and sperm. So I definitely have some patients whose numbers were all good, and then we were seeing the eggs didn't look so good or we didn't get as many embryos. But luckily, sometimes we really do get to those healthy embryos and then they're successful, which is wonderful, So the other thing that's hard is that some insurances, right? So I know some people are not lucky to have insurance and are unfortunately paying self-pay, which is really, really hard. And I know, so that is one consideration to look at. What are the success rates when I'm doing this? And then on the other hand, patients who do have insurance, which is good, sometimes the insurance mandates that you do a certain number of IUIs before IVF, unless you have something else, another diagnosis. But yeah, in your situation, I would definitely start looking at one of those treatments earlier now. Can the doctor recognize the chance of embryo transfer at the moment of doing it? Unfortunately not. I wish I knew. We cannot. We know that we feel good things are if a transfer is easy, if the catheter is clear afterwards. Obviously, we make sure the embryo came out all the time. We can always put it back. I've had patients that's happened to, and people who have beautiful babies, even when that happened. But no, we don't know at that time, and we wish we could tell you more. You're right. Answer that. I'm sorry. There's a lot of questions. These are really wonderful. Okay. I just ovulated for the first time on letrozole 5 milligrams. I'm super excited. I'm super excited for you too. I'm wondering if low motility on the semen analysis is detrimental to becoming pregnant without IUI or IVF. I think there's a small part of male factor. Okay. So yes, it depends on the motility though. So I don't know. So if you have If there still is a really good total motile count of sperm, you could definitely get pregnant on your own. If this motility is lower, you may want to look into either IUI or IVF. And if we know that you respond well to letrozole, it might be good to combine the IUI first. And it's important to know that it just depends on the sperm. If there really is severe male factor where the total motile count is less than 5 million, if you look at all the numbers and you do the math of the sperm, it's going to be IVF is going to be your better chance. Now, that having been said, was the semen analysis only done once? Because one semen analysis on one day doesn't necessarily mean that there's an issue, right? The sperm's life cycle is about 72 days, and we should get a second one just to confirm too. It could be that your partner was sick 3 months before. I always say repeat a semen analysis and maybe have him see a male fertility specialist, a urologist that specializes in male fertility, to see if there's anything we can do to improve. Some of my urology friends have, recommend things like, CoQ10, male vitamins, like the Conception and other brands of the vitamins. So sometimes that can be really helpful. Also be helpful if there really is an issue to get an exam. I always say to my male patients, I really want you to be checked out. I want to make sure your health is okay, and see the urologist, have a testicular exam, have a male hormone panel, and see if there's anything that we can do. Is there a varicocele? Is there low testosterone? Is there something you can do? So just to go back to your question there, if it's really low motility, one of those may be better than just having intercourse. I think if it's really mild and it hasn't been checked again, you just might want to check the semen analysis again. And remember, it only takes one, but I wouldn't waste too much time. And then maybe just have him evaluated too, just in case. Okay. This is a question about, in addition to the prenatal, do I need to supplement vitamin D3 before pregnancy? It is. We have, again, we don't know the definitive answer, but we do have a lot of, studies on fertility and vitamin D and miscarriage rates in vitamin D. I think it's one of those things that's really easy to fix, and it's really important for your bones and for other organ systems. So I do usually tell my patients add about 2,000 a day with your prenatal vitamin, and I do check the levels to make sure they're okay. Again, there is some debate about this, but I think it's something that's super easy to fix, that just make sure that that's okay. Do I think that's the answer for everyone? Not necessarily, but I think it's important to just make sure you have everything, like you're just trying to do everything possible. And so adding that to the prenatal is good. I think someone else also asked a question about the prenatal. You want to have at least 800 micrograms of folic acid. If you are on certain seizure medications, or you've had a history of a neural tube defect in the past in a child you've had, then you need to be on a much higher dose of folic acid, 4 milligrams of folic acid, okay, like 4,000 micrograms. But for most patients, it's just over 800 micrograms. Also the omega-3 fatty acids, DHA, those are good for neural development, brain and eye development of baby. And I do like to make sure you have the vitamin D. Okay, so that's really important. Have you had luck with IVF for women that have been diagnosed with unexplained fertility? No issues with health, but after 5 failed IUIs and a canceled egg retrieval from being a very low responder to stims, I'm trying to stay hopeful. Again, I'm so sorry you're going through all of this. Yes, we have. Certainly it depends on the age. Your age is your primary predictor for the success of these cycles, but I would say one canceled egg retrieval, please do not get discouraged. I would sit down with your doctor, talk to them about, what's our best protocol? Can we change this? What happened? Remember, every month we have a different group of eggs. And I've had patients who've done the same protocol in different months because they just really liked it, and they've had different responses. Again, we don't always just want to do the same thing. We want to think about it and say, what is right for you? So I would say, with being a slow responder to the stimulation and that being canceled, okay, do we need to start with a higher dose? Do we need to do a different type of protocol? I would not give up. And definitely we've had success. How can I increase my chances of pregnancy after the implantation? I wish there was I know you would all do everything I tell you to do. What you need to do is continue taking whatever, like the estrogen, progesterone, whatever hormones. Unfortunately, after the implantation, it is out of your hands. You have done everything right until then. I know it's really hard, but just continuing to take your medications as you're prescribed. And I like to just say, be cautiously optimistic because, you still have a really good chance. This is a good question. Does a special diet affect fertility in general? We don't have a magical diet. I wish we did. Because we all know people who are unhealthy who get pregnant. But for us going through fertility issues, right? And it is always good to be as healthy as we possibly can be, right? And my patients will tell you this, and I know, if there are some of you here, everything in moderation. Like, I don't want you to drive yourself crazy. It's not fair, right? What we can do is we can do everything possible, eating lots of fruits and vegetables, really good proteins, really good fats, moderate exercise, limiting caffeine. Some people tell you to completely eliminate it. I don't think it's necessary. I would just stick to less than 200 milligrams a day. And, some people say really higher protein, focusing on good fats, that's really helpful. If there's a certain diet that's better for you, like if you have a gluten sensitivity or you have something that works for you, I think that's okay to do. I just don't think there's a one size fits all. And that's just me. I think we just have to be as healthy as possible. The eggs and sperm like antioxidants. So definitely eating much less processed food, eating more at home, cooking more at home as much as you can, but you have to treat yourself every once in a while and you have to be a normal person, right? So just doing the best you can is what I think you should do. Yeah, my first transfer was not successful. How can I improve my confidence and pregnancy rate in my next transfer? Again, I'm so sorry. I know that is so frustrating, but I will say this, that, many patients' first transfer doesn't work. And so again, what you want to do is sit down with your doctor, go through and say, do we have the right protocol? What is my next embryo that we're going to use? What is the quality? Is it tested or not? What are my chances? And then make sure that your testing is updated, that everything, that nothing has been missed there and that we have the best protocol for you. I know it's really hard, but what I would say is, again, remain cautiously optimistic and make sure that all your questions are answered and make sure that you feel good about the protocol you have moving forward. Okay. Do we have any more here? So you guys are amazing. You're amazing. Again, I wish we were together. We're sort of together. It's just feel. So do success rates increase with PGT-A or no? So really good question. So it depends on the age. In younger patients, you're still going to have quite a good chance of having a successful pregnancy with an embryo transfer because many of the embryos are likely genetically normal. So if you look, I wish I could actually show you a graph. If you look at a graph there's increased rates of aneuploidy or genetically abnormal embryos as we get older. So kind of even in the younger group. So if you look, even in the donor egg group, right? These are young women who are giving their eggs to other women who need help, right? There can be about up to a 30% rate. At the same time, each one of those embryos is still roughly 50% chance. And if you test them, it doesn't get much higher than around 60%. So you can see that in the younger patients, it may not do much of a difference, under 35. Over 38, we see over 70% abnormal embryos, and even over 42, you may see up to 80 to 90% abnormal. And in some patients, unfortunately, you may see 100% abnormal embryos, which is really sad, but many times you just need to do multiple cycles. So that having been said, if your embryo is tested, yes, it's going to give a little higher chance for success, but it depends on the age at which the embryo was created and may not make a huge difference. Also remember that it's not perfect, so there may be 1 to 2% error. There also are mosaics, if anyone's heard of that. Some cells are healthy and some cells are not. And there's some data that maybe some of these mosaics could be live births. So that's one thing you always have to take into account. Is this right for me at my age? And I have patients of all ages who've decided to do it or not, but we just decided together based on their wishes and their medical diagnosis and just kind of the whole picture, right? That's really important. Thank you. So good question. If you only retrieve 4 eggs and 2 make it to embryos, is that okay? I think that's great. That is 50%, and I'm really happy. So that's a really good percentage of that. So I would say you did wonderfully. I'm very happy for that. I think someone did ask about making an appointment. I think they put our website on the chat. And if you want, you could put the phone number of the office too. Emily, she's Emily and Zoe are in behind the scenes. They're helping me. They're amazing. Depending on age, how many eggs do you typically transfer? Good question. So embryo, it's what we're testing, embryo. Remember, an egg and sperm are going to come together to make an embryo. So typically we recommend and especially in this day, like 2023, we're recommending one healthy embryo at a time. Why? Because we do want to reduce the risk of multiple births. Again, this is like there's a lot of people that have twins and triplets and more that are healthy, but the reality is that the chance of loss and the chance of pregnancy complications is really increased dramatically, unfortunately. So we recommend one healthy embryo at a time at all ages. So if the embryo is tested across all ages, we recommend one at a time. In some situations with patients who are older, who may not want to do genetic testing, we may recommend, or they may choose to do two or more embryos depending on age. And we do have guidelines from ASRM that we do follow. But of course, again, I talk to my patients about their wishes. But we do want to avoid you having a high risk pregnancy. So it's real, and especially starting out, it is always good to start with one. I had patients who've transferred 2 embryos or more. Yes, for certain situations we have, but again, we like to start with one at a time. And again, remember, you're giving each embryo the best chance in that month, right? So, but it is different if you're 42 and not doing genetic testing. It may be reasonable, but more than that. Okay. Let me go through more questions. Good question. So for people who need to order sperm, do we wait to order from a donor after all testing is completed? I always say yes. This is what I do when I first talk to a patient about donor sperm. I always say, here is our, here's our list of, recommended sperm banks. Of course, I always tell patients, if you find another one, let me know, and I can always just investigate and make sure they're doing the right, testing, and the right, regulations. So what I usually tell patients is let's do your testing. So let's see, what if your tubes are blocked and you have to do IVF anyway? So that would be, you would be buying a different number of vials, different types of vials, because in the sperm banks, they'll have unwashed, washed sperm, IUI vials, IVF vials. And a lot of my patients are like, oh my gosh, Dr. Bachman, I don't know what to buy. So I always tell my patients when I first meet you, go ahead, just take a look, make a short list, don't buy anything. Let's do your testing, and then we'll decide together. And again, it's based on what are the goals of your family, what kind of treatment might you do, how many cycles, how many children do you want, do you want them to have the same sperm donor? And then so we can decide together at that point how many vials of what type of sperm you should buy. Also, these sperm donors are tested for what's called carrier screening. Do they carry a certain disease? And now that we're doing these panels are 200 to 400 genes that are tested. So somebody's positive for something. And so I usually also tell my patients, just wait and hold on so we can see, is this donor positive for a certain condition? Because then we want to make sure you're tested for that condition before you proceed with that donor. So I do like to wait, but, especially if, if someone is, there's a donor that you really like, you want to tell your doctor, hey, can we get some of this testing done so I can know if I can order this or not? So yeah, I like to make that decision with you and then help you through that process. This is a great question about subclinical hypothyroidism. We're a queer couple. I'm 30 and planning to do IUI. All my tests are clear except subclinical hypothyroidism, TSH 3.8. What are your thoughts about treating the thyroid versus just trying, given that we'll be paying for sperm each month? I do agree. I know you have to pay for sperm each month. It's really hard. Typically, again, there are studies that are showing both sides of this. I like to actually check thyroid antibodies in patients too. And if the thyroid antibodies are positive, I definitely treat them for that. But I still try to make sure the TSH is 2.5 or less for the treatment. And I think it may be helpful just to make sure everything is normal. Again, it's likely that number is going to be normalize pretty quickly. So you could probably do them in parallel. But again, I would probably check your thyroid antibodies too, and then maybe recheck the TSH, and then you can decide with your doctor. I usually start the lowest dose of Synthroid. It's category A in pregnancy. And so it just might be helpful to do that, just because, you know, you are paying for everything and we want to make sure everything is optimized. I'm sure there's a lot of people who have no idea that their TSH is 3.8 and they're getting pregnant. We have some data on improved implantation. Again, I would check the thyroid antibodies and probably start treating it as well. Another patient I just asked about DHEA. I think I answered that question the first time, knowing that I'm a diabetic. Any advice? I would just make sure that your diabetes is under control, the hemoglobin A1C is in a normal range, that you're seeing your medical endocrinologist, and that like your blood sugar levels are good. I would also see maternal fetal medicine as a preconception consult. I often recommend a preconception consult with maternal fetal medicine for my patients. You know, if they have any medical issues, just to talk about what are the, you know, what is the monitoring in pregnancy, when growth scans, testing for the baby and everything, knowing those risks. Remember, with diabetes, if the hemoglobin A1C is very high, there's a high rate of birth defects. And so we want you to have the healthiest pregnancy possible, healthiest baby possible. So make sure that your diabetes is under control. You're seeing your medical endocrinologist, your reproductive endocrinologist knows about this. And then also maybe you have a maternal fetal medicine preconception consult about it. This is a good question. Under what conditions are immune transfer protocols considered? Is it only after there are losses? So certainly, unfortunately, we need more data on this. I really think that reproductive endocrinology is something that's not well studied enough, and I think we really need a lot more information. There are some situations where patients are either not, you know, implanting, or they're having multiple miscarriages, that we will maybe consider some of these options like a low-dose steroid, aspirin, Lovenox, and some other medications. Again, remember, we're falling into this gray area. We definitely do this, you know, if someone is positive for the antiphospholipid syndrome, we do use aspirin and Lovenox in pregnancy if you're definitely positive for that. We do have some patients who you know, are having multiple miscarriages without any explanation, or multiple implantation, you know, after, you know, failing multiple implantations. So that can be very frustrating. Again, I usually I kind of look at the whole picture together. Is the uterus okay? Is the uterus still normal? You know, do we have any sign, you know, how are the labs? How is the thyroid? How are, you know, any infections? And, you know, making sure we've done, if you've had 2 or more losses, we've done a full recurrent pregnancy loss workup. So yeah, I wouldn't just use an immune protocol without a reason for it. Because again, the data are not, you know, we don't have definitive data exactly on what we should do for some things. So for the antiphospholipid syndrome, that's definitive. But for other situations, we are falling into this gray area. But again, we do everything we can for our patients in trying to help them be successful. So I wouldn't put you on a steroid for no reason. I think that we don't want to give you risks. So if that makes sense. Okay. So this is really a good question. So I'm 38. When my GYN wasn't concerned with me conceiving, but when another doctor looked at the same labs, the FSH value was 12.3. I was told that IVF most likely would have been approved. What are your thoughts on looking at just that value? Everything else is within normal limits for me. So you have a 5-year-old healthy girl conceived by IUI one time. Perfect. Okay. So we're going back to age is our primary predictor, right? So FSH, AMH, follicle counts, they can tell me how you may predict a treatment. I mean, how you may respond to treatment. They do not predict live birth. So it is unfortunate. I know you said you had a 5-year-old healthy girl, so she was probably conceived about 6 years ago, right? So, you know, 32, the chances are a lot higher, right, to get pregnant. At 38, and then that FSH value, again, depending, you have to look at the immunoassay, sometimes just what that level, but it is a borderline or slightly elevated level in our lab. So what I would say is that does not mean you cannot have a baby. What it means is I would be a little more proactive about things And the fact that with being 38, sometimes again, a larger percentage of those eggs are not healthy. So IUI success would be lower at 38 and IVF success would be a lot higher. Now, that does that mean you can't try an IUI or two? No, but IVF would offer you a higher chance for success. And we look at this Boston IVF study, looking at women between the ages of 38 to 42, and IVF just offered them much higher chance for success. So it may be smarter for you to just go to the treatment that's going to give you the higher chance for success in the shorter amount of time. But again, please talk to your doctor and do what you feel comfortable with. I would definitely be more proactive. Again, the FSH of 12 does not mean you can't have a baby. Okay. And there are some patients who conceive on their own with that too. But we do want you, if you haven't conceived, then we do want you to get the help you need. Okay. I recently went through a stimulation cycle where under 50% of my retrieved eggs, 5 of 13 were mature. If you have any suggestion for improving this rate, it was an aggressive protocol. Okay. So it would be very helpful for me to actually see the protocol, but I'll give you some suggestions on things that I do. Sometimes I want a much more even response. So I may even start a little lower and go a little lower and longer. Depending, I may still stay at the high dose. And then maybe go a little further in the cycle, depending on the sizes. Maybe I'll go to a little bigger sizes. It would help me to see your estrogen levels. So things we could decide are, do we change the protocol? Do we change the dose? Do we, pre-treat you with either estrase or pill beforehand to get a more even growth? Do we push a little longer? Do we use maybe like 2 trigger, double trigger? There's some studies that looked at adding some FSH with the trigger too. So there's a lot of different things that I might do. Of course, it'll be helpful to see the protocol, but I would definitely sit down with your doctor and look at that. But again, changing protocol, changing dose, timing, going longer, maybe some pre-treatment with estrase or OC or pills, or like a double trigger, or adding some FSH with the trigger. Okay, hopefully that might be helpful. This is, again, you go back in April. So after the DNC, I would, I know it's hard to look at that prenatal bottle, but I would still take the prenatal vitamins. I would take some vitamin D, and I would just be very kind to yourself and, just do the best you can to, give yourself, your body and your mind time. I think, I tell my patients, medically, you're going to be okay after DNC. It's emotionally, that's the hardest part. So, just doing the best you can and talking to a therapist if you need to, talking to a friend that you trust. Sometimes like, friends and family members can be good or really bad, right? So some people are really helpful and they say the right thing, and some people say the most terrible things to you, right? I'm sure everyone knows that. But just with someone you feel like you trust and that is, really there just listening to you. And a lot of times I tell my patients that it may be good to just talk to a therapist who's just there for you and they're not giving you, terrible advice, and most people mean well, right? But it can be hard to go through this. But again, taking your prenatal, taking some vitamin D, eating as healthy as you can, and just being really nice to yourself. That's the best you can do. And I think, medically you'll be okay. It's just emotionally, it is really hard. It's really hard. How long do you generally recommend waiting to initiate FET protocol after endo excision surgery? It depends. I think if we feel like the excision went really well, you could potentially just initiate the next month. If we feel like there was a lot of endometriosis and you should be maybe on a couple months of suppression, I might suppress you for 1 or 2 months after and then start that. I think it just depends on the level of endometriosis and then also the history. Have you failed other transfers? Have you not? What's happened, right? Have you tried a transfer before? Have you had a miscarriage? So kind of looking at the whole picture, but I would say you could potentially do the next month or maybe do some suppression for a couple months first. Okay. How many cycles do you recommend of IUI for donor sperm? This is a great question. Again, it depends on your age and your wishes, right? So typically in someone who, remember, if you're younger, right, and you're haven't tried to get pregnant before, it's a little different than the infertility patient. But typically, we at least recommend trying 3 to start off with. I have had patients who they didn't really want to do IVF, or they weren't ready and they got pregnant on that 4th or 5th, but that can be very frustrating. But I would say many patients conceive. It's, if you're younger and you're not infertile, everything's normal. It's roughly about 20% a month, because it's just kind of your normal chance for pregnancy. So I would say, try 3 cycles and then regroup with your doctor. If you're older, you may not want to try that many, right? You might, because the donor sperm is really expensive. So if you're over 38, I know it can be hard sometimes to think about going directly to IVF if you've never even tried before, but it could give you the better chance for success. Also, you have to think about, again, what are the wishes for your family? How many children do we want? Do both my partner and I want to get pregnant? Do only one of us want to get pregnant? Do we want to use both of our eggs? So we can talk to you about, do you want to do IUIs? Do you want to do IVF? How many cycles? So again, that question's, I don't want to give you an exact answer. In general, in a younger patient, I may start with at least 3, but depending on age, we may make a different plan. And then depending on your wishes for your family. This is a good question. So an embryo transfer prep question. We had 1 transfer last year, but unsuccessful. We have another chance, but have been waiting for a clear triple layer lining for several period cycles. Thickness has been great, but midline not continuous and endometrium still dense. A bit dense on ultrasonogram. Okay. Can the transfers be successful in less defined uterine lining? So what you're talking about here is my lining trilaminar? I don't know if most of you have, if you've turned around, looked at the ultrasound, where the lining can have these 3 lines, right? And that's kind of the appearance we really want it to look before we start your progesterone, that trilaminar appearance. Does everyone have that? Not necessarily. So sometimes it can be a little intermediate where it kind of looks like that, but not really, or sometimes it can be very homogeneous and completely fuzzy. I will say that there are studies that show that implantation rates do decrease. They're best with the trilaminar and not as well. But I have had many patients who we've done everything possible and they don't make that trilaminar lining, or they're somewhere in the middle, or even the kind of the fuzzy looking lining, and they are successful. So they can be successful. But what I recommend is, if that's the first time you've seen it, is trying again, right? And seeing what can we optimize this? Can we get the best lining possible? I would rather have a little thinner lining that looks trilaminar, but at the same time, I've had some patients who've had intermediates or kind of more fuzzy, shall we say, homogeneous looking linings that did get pregnant. So everyone's different. Again, they can be successful. But I always like to say, let's make sure we've tried everything possible before just moving on with your precious embryo. And I'd rather cancel you, not because I want to cancel you, because I want to make sure it's the best outcome possible. I'm 30, my husband is 40. I had a baby at 18 and we've been trying for 2 years. We've been tested until we have unexplained. We're leaning towards IVF as we'd like to grow the family sooner, not continuing to wait. Ideally, we would like to have twins. Is this recommended? This is a really good question. Again, because you're 30, you have a really good prognosis. And so at this point, most reproductive endocrinologists would recommend doing 1 healthy embryo at a time. It can split. You can get identical twins. So if we end up putting 2 in, your twin rate is going to be 30%, and then the triplet rate is going to go up to about 1% with those, whereas your identical twin rate will be about 1% if we just put one embryo in. So we really would recommend that you do 1 at a time. Obviously, you should talk to your doctor, and again, we just want you to have the healthiest pregnancy possible. So it's really possible to have those embryos already made, right? Put 1 in, have a baby, and then we usually say at least wait a year between babies, and then we'd have those embryos already ready for you to do another transfer and have another child at 32 or so. Okay. I think we're out of time now. If there are any questions that I had, I'm so sorry. I tried to get to all of them. We had multiple different ways. This was really fun. Again, I wish I could see you all in person. So if you have any other questions, you can send them and they can send them to us. We're always happy if you want to make an appointment with us or any of the other, Boston IVF offices. If you're, in our area, we'd love to see you. And we do telehealth consults to make it easier for you. You can come in person if you want to. Of course, we do all the testing in person. We have a wonderful group. I really, I love our office. I think, we really strive to give you really individualized care. We have, like we said, 3 physicians. We have an incredible nurse practitioner, Lauren Rainey, an incredible PA, Julia Bergerman, and we have a wonderful staff, our embryology team, our front desk, our coordinators, our nurses, our andrologists, our administrative staff members. They're amazing. And, we want to give you the best care possible. We want to individualize your care, but we also have the benefit that we're part of the Boston IVF Network. And, we have access to, all these other colleagues, and we meet once a month, and we can bring really difficult cases to the group and talk about them and make a new protocol for you, or think about things for you, or think about patients who've had like either really difficult, either multiple miscarriages or difficult IVF stimulations or failed transfers, and really try to help you the best we can. So we feel like we have the best of both worlds, which is amazing. And, we're all here to help you. Please reach out if you need any help. Also, make sure you're asking questions to your doctor, and make sure like you're getting the answers you need. So we're all here for you. And I really appreciate all of you taking time, and I hope to see you again soon. And we will, you can send us messages if you need, and we're happy to get back with you if you want to make an appointment. Okay. All right. Have a good night. Bye.